Chapter 8 of Hunquera for Histology 8.3 Bone. As the main constituent of the adult skeleton, bone tissue provides solid support for the body, protects vital organs such as those in the cranial and thoracic cavities, and encloses internal, like medullary cavities containing bone marrow, where blood cells are formed. Bone or osseous tissues also serve as reservoir for calcium, phosphate, and other ions that can be released or stored in controlled fashion to maintain constant concentration in body fluids. In addition, bones form a system of levers that multiply the forces generated during skeletal muscle contraction and transforms them into bodily movements. This mineralized tissue therefore confers mechanical and metabolic functions to the skeleton. Bone is a specialized connective tissue composed of calcified extracellular material, the bone matrix, and the following three major cell types. Osteocytes, which are found in the cavities or lacunae between bone matrix or lamellae, with cytoplasm processes in small canaliculi that extend into the matrix. Osteoblasts, or growing cells, which synthesize and secrete organic components of the matrix. Osteoclasts, which are giant multinucleated cells involved in removing calcified bone matrix and remodeling bone tissue. Because of metabolites are unable to diffuse through the calcified matrix of bone, the exchanges between osteocytes and bone capillaries depend on communication through the very thin cylindrical spaces of the canaliculi. All bones are lined on their internal and external surfaces by layers of connective tissue containing osteogenic cells, or endosteum on the internal surface surrounding the marrow, and perosteum in external. Because of its hardness, bone cannot be sectioned routinely. Bone matrix is usually softened by immersion in decalcifying solutions before paraffin embedding, or embedded in plastic after fixation and sectioned with a specialized microtome. Bone cells. Osteoblasts originating from mesenchymal stem cells. Osteoblasts produce the organic components of the bone matrix, including type 1 collagen fibers, proteoglycans, and matricellular glycoproteins such as osteonectin. The position of the inorganic components of bone also depends on the osteoblast activity. Active osteoblasts are located exclusively at the surface of bone matrix, to which the bone are bound by integrins, typically forming a single layer of cuboidal cells joined by adherent and gap junctions. When their synthetic activity is completed, some osteoblasts differentiate as osteocytes, entrapped in matrix-bound lacunae. Some flatten to cover the matrix surface as bone-lying cells, and the majority undergoes apoptosis. During the processes of matrix synthesis and calcification, osteoblasts are polarized cells with ultrastructural features denoting active protein synthesis and secretion. Matrix components are secreted at the cell surface in contact with the existing bone matrix, producing a layer of unique collagen-rich material called osteoid between the osteoblast layer and pre-existing bone surface. This process of bone oppositional growth is completed by subsequent deposition of calcium salts into the newly formed matrix. The process of matrix mineralization is not completely understood, but basic aspects of the process are shown in Figure 8-4. Prominent among the non-collagen proteins secreted by osteoblasts is the vitamin K-dependent polypeptide osteocalcin, which, together with various glycoproteins, binds calcium ions and concentrates this mineral locally. Osteoblasts are also release membrane-enclosed matrix vesicle, rich in alkaline phosphatase and other enzymes whose activity raises the local concentration of phosphate ions. In the microenvironment with high concentrations of both these ions, matrix vesicle serves as foci for the formation of hydroxyapatite crystals, which is the first visible step in calcification. These crystals grow rapidly by accretion of more mineral and eventually produce a confluent mass of calcified material embedding the collagen fibers and proteoglycans. Medical application. Cancer originating directly from bone cells, a primary bone tumor, is fairly uncommon, or 0.5 of all cancer deaths. Although cancer called osteosarcoma can arise in osteoprogenitor cells, the skeleton is often the site of secondary metastatic tumor, however, arising when cancer cells move into bones via small blood or lymphatic vessels from malignancies in other organs, most commonly the breast, lung, prostate gland, kidney, or thyroid. Osteocytes. As mentioned, some osteoblasts become rounded by the material they secrete and they differentiate as osteocytes, enclosed singly within the lacunae, spaced throughout the mineralized matrix. During the transition from osteoblasts to osteocytes, the cells extend many long dendritic processes, which also become surrounded by calcifying matrix. The processes thus come to occupy the many canaliculi, 250 to 300 nanometer in diameter, radiating from each lacuna. Diffusion of metabolites between osteocytes and blood vessels occurs through the small amount of interstitial fluid in the canaliculi between the bone matrix and the osteocytes and their processes. Osteocytes also communicate with one another and ultimately with nearby osteoblasts and bone lining cells via gap junctions at the end of their processes. These connections between osteocytes processes and nearly all other bone cells in the extensive lacunar canalicular network allow osteocytes to serve as mechanosensors detecting the mechanical load on the bone as well as the stress or fatigue-induced microdamage and to trigger remedial activity in osteoblast and osteoclast. Normally, the most abundant cell in the bone, osteocytes, exhibit significantly less RER, smaller Golgi complexes, and more condensed nuclear chromatin than osteoblasts. Osteocytes maintain the calcified matrix, and their death is followed by rapid matrix resorption. While sharing most matrix-related activities with osteoblasts, osteocytes also express many different proteins including factors with paracrine and endocrine effects that help regulate bone remodeling. Medical application. The extensive network of osteocyte dendritic processes and other bone cells has been called mechanostat, monitoring mechanical loads within bones and signaling cells to adjust ion levels and maintaining the adjacent bone matrix accordingly. Resistance exercise can produce increased bone density and thickness in affected regions, while lack of exercise or the weightlessness experienced by astronauts lead to decreased bone density, due in part to lack of mechanical stimulation of bone cells. Osteoclast. Osteoclasts are very large motile cells in multiple nuclei that are essential for matrix resorption during bone growth and remodeling. The large size of and multinucleated condition of osteoclasts are due to their origin from the fission of bone marrow-derived monocytes. Osteoclast development requires two polypeptides produced by osteoblasts, macrophage colony stimulating factor, or MCSF, and the receptor activator of nuclear factor Kb ligand, or RANKL. In areas of bone undergoing resorption, osteoclasts of bone surface lie within enzymatically etched depressions or cavity in the matrix, known as resorption lacunae or hoe-shaped lacunae. In an active osteoclast, the membrane domain that contacts the bone forms a circular sealing zone that binds the cells tightly to the bone matrix and surround an area with many surface projections, called a ruffled border. This circumferential sealing zone allows the formation of specialized microenvironment between the osteoclasts and the matrix in which bone disruption occurs. Into the subcellular pocket of the osteoclast, into the subcellular pocket, the osteoclasts pumps protons to acidify and promote dissolution of the adjacent hydroxyapatite and releases matrix metalloproteinases and other hydrolytic enzymes from lysosome-related secretory vesicles for the localized digestion of matrix protein. Osteoclast activity is controlled by local signaling factors from the other bone cells. Osteoblasts activated by parathyroid hormone produce MCF, RANKL, and other factors that regulate the formation and activity of osteoclast. Medical application. In the genetic disease osteoporosis, which is characterized by a dense heavy bones or marble bones, the osteoclast lacks the ruffled borders and bone resorption is defective. This disorder results in overgrowth and thickening of bones. often with obliteration of marrow cavities, depressing blood cells formation and causing anemia and the loss of white blood cells. The defective osteoclasts in most patients and osteoporosis have mutations in genes for cells proton ATPase pump or chloride channels. Bone matrix. About 50% of the dry weight of bone matrix is inorganic materials. Calcium hydroxyapatite is most abundant. Bicarbonate, citrate, magnesium, potassium, and sodium ions are also found. Significant quantities of non-crystalline calcium phosphate are also present. The surface of hydroxyapatites crystals are hydrated, facilitating the exchange of ions between the mineral and body fluids. The organic matter embedded in the calcified matrix is 90% type 1 collagen, but also includes mostly small proteoglycans and multi-adhesive glycoproteins such as osteonectin. Calcium-binding proteins, notably osteocalcin, and phosphatases, released from cells in matrix vesicle, promote calcification of matrix. Other tissues rich in type 1 collagen like osteocalcin and matrix vesicle, and therefore do not normally become calcified. Dissociation of mineral with collagen fibers during calcification provides the hardness and resistance required for bone function. If a bone is decalcified by a histologist, its shape is preserved but it becomes soft and pliable like other connective tissues. Because of its high collagen content, the calcified bone matrix is usually acidophilic. Periosteum and endosteum. External and internal surfaces of all bones are covered by connective tissue of the periosteum and endosteum respectively. The periosteum is organized much like the perichondrium of the cartilage, with an outer fibrous layer of dense connective tissue containing mostly bundled type 1 collagen, but also fibroblasts and blood vessels. Bundles of periosteal collagen, called perforating or Sharpie fibers, penetrate the bone matrix and bind the periosteum to the bone. Periosteal blood vessels branch and penetrate the bone, carrying metabolites to and from bone cells. The periosteum inner layer is more cellular and includes osteoblasts, bone lining cells, and mesenchymal stem cells referred to as osteoprogenitor cells. With the potential to proliferate extensively and produce new osteoblasts, osteoprogenitor cells play a prominent role in bone growth and repair. Internally, the very thin endosteum covers small tuberculae of bony matrix that project into bone marrow cavities. The endosteum also contains osteoprogenitor cells, osteoblasts, and bone lining cells, but within a sparse, delicate matrix of collagen fiber. Medical application. Osteoporosis, frequently found in immobilized patients and in postmenopausal women, is an imbalance in skeletal turnover so that bone desorption exceeds bone formation. This leads to calcium loss from bones and reduced bone mineral density or BMD. Individuals at high risk for osteoporosis are routinely tested for BMD by dual energy X-ray absorptiometry. Types of bones. Gross observation of bone in cross-section shows a dense area near the surface corresponding to compact or cortical bone, which represents 80% of the total bone mass, and deeper areas with numerous interconnecting cavities called cancellous trabecular bone. Trabecular bone consisting about 20% of total bone mass. Histological features and important collocations of the major types of bone is summarized at Table 8-1. Table 8-1. Summary of bone types and their organization. Woven bones are newly calcified. Histological features, they are irregular and random arrangement of cells and collagen. It is likely calcified. It is found in developing and growing bones and hard callus of bone fractures. Synonyms are, it can also be called immature bone, primary bone, or bundle bone. Second type is the lamellar bone or the remodeled from woven bone. Histological features, they are parallel bundles of collagen in thin layers or lamellae with regularly spaced cells between, and it is heavily calcified. It is found in all normal regions of adult bones. It can also be called mature bone or the secondary bone. Compact bone, which is 80% of all lamellar bone, is histological feature is it has parallel lamellae or densely packed osteons with interstitial lamellae. It is found in thick outer regions beneath periosteum of bones. It is also known as cortical bone. Cancellous bone, which is 20% of the lamellar bone, it has interconnected thin spicules of tubercally covered by endosteum. It is found in the inner regions of bone adjacent to marrow cavities. It is also called spongy bone, trabecular bone, and medullary bone. In long bones, the bulbous ends, called epiphyses, are composed of cancellous bone covered by a thin layer of compact cortical bone. The cylindrical part, or the diaphysis, is almost totally dense compact bone, with a thin region of cancellous bone on the inner surface around the central marrow cavity. Short bones, such as those in the wrist and ankles, usually have cores of cancellous bone surrounded completely by compact bone. The flat bones that form the calvaria or skull cap have two layers of compact bone called plates, separated by a thick layer of cancellous bone called diploe. At the microscopic level, both compact and cancellous bones typically show two major types of organization: mature lamellar bone, which matrix existing as discrete sheets, and woven bone, which is newly formed with randomly arranged components. Lamellar bone. Most bone in adults, compact or cancellous, is organized as lamellar bone, characterized by multiple layers of lamellae or calcified matrix, each 3 to 7 micrometer thick. The lamellae are organized as parallel sheets or concentrically around the central canal. In each lamella, type 1 collagen fibers are aligned, with the pitch of the fiber's orientation shifted orthogonally by about 90 degrees in successive lamellae. This highly ordered organization of collagen within lamellar bone causes birefringence with polarizing light microscopy. The alternating bright and dark layers are due to the changing orientation of collagen fibers in the lamellae. Like the orientation of wood fibers in plywood, the highly ordered alternating organization of collagen fibers and lamellae adds greatly to the strength of the lamellar bone. An osteon or Haversian system refers to the complex of concentric lamellae, typically 100 to 250 micrometer in diameter, surrounding a central canal that contains small blood vessels, nerves, and endosteum. Between successive lamellae are lacunae, each with one osteocyte, all interconnected by canaliculi containing the cell's dendritic processes. Processes of adjacent cells are in contact via gap junctions, and all cells of an osteon receive nutrients and oxygen from vessels in the central canal. The outer boundary of each osteon is a layer called the cement line that includes many more non-collagen proteins in addition to mineral and collagen. Each osteon is a long, sometimes bifurcated cylinder, generally parallel to the long axis of the diaphysis. Each has 5 to 20 concentric lamellae around the central canal and communicates with the marrow cavity and the periosteum. Canals also communicate with one another through transverse perforating canals or development canals that have few, if any, concentric lamellae. All central osteonic canals are perforating canals formed when matrix is laid down around areas and with pre-existing blood vessels. Scattered among the intact osteons are numerous irregularly shaped groups of parallel lamellae called interstitial lamellae. These structures are lamellae remaining from osteons partially destroyed by osteoclasts during growth and remodeling of bone. Compact bones, like in the diaphysis of long bones, also includes parallel lamellae organized as multiple external circumferential lamellae, indicate immediately beneath the periosteum, and fewer inner circumferential lamellae around the marrow cavity. The lamellae of these outer and innermost areas of compact bone enclose and strengthen the middle region containing vascularized osteons. Bone remodeling occurs continuously throughout life. In compact bone, remodeling resorbs parts of old osteons and produces new ones. As shown in Figure 8-11, osteoclasts remove bone from small and form small tunnel-like cavities. Such tunnels are quickly invaded by osteoprogenitor cells from the endosteum or periosteum and sprouting loops of capillaries. Osteoblasts develop, line the walls of the tunnels, and begin to secrete osteoid in a cyclic manner, forming a new osteon with concentric lamellae of bone and trapped osteocytes. In healthy adults, 5 to 10% of the bone turns over annually. Medical application. The antibiotic tetracycline is a fluorescent molecule that binds newly deposited osteoid matrix during mineralization with high affinity and specifically labels new bone under UV microscope. This discovery led to methods of measuring the rate of bone growth, an important parameter in the diagnosis of certain bone disorders. In one technique, tetracycline is administered twice to patients with an intervening interval of 11 to 14 days. Bone biopsy is then performed, sectioned without decalcification, and examined. Bone formed with tetracycline was present appears as fluorescent lamellae, and the distance between the labeled layers is proportional to the rate of bone appositional growth. This procedure has a diagnostic importance in diseases such as osteomalacia, in which mineralization is impaired, and osteotis fibrosa cystica, in which increased osteoclast activity results in removal of bone matrix and fibrous degeneration. Woven bone. Woven bone is non-lamellar and characterized by random deposition of type 1 collagen fibers and is the first bone tissue to appear in embryonic development and in fracture repair. Woven bone is usually temporary and is replaced in adults by lamellar bone, except in a very few places in the body. For example, near the structures of the calvaria and in the insertion of some tendons. In addition to the irregular interwoven array of collagen fibers, woven bone typically has a lower mineral content. It is easily penetrated by X-rays, and a higher proportion of osteocytes than mature lamellar bones. These features reflect the facts that immature woven bone forms more quickly but has less strength than lamellar bone. Osteogenesis. Bone development or osteogenesis occurs by one or two processes. Intramembranous ossification, in which osteoblasts differentiate directly from mesenchyme and begin secreting osteoid. And second is endochondral ossification, in which pre-existing matrix of hyaline cartilage is eroded and invaded by osteoblasts, which then begin osteoid production. The name refers to the mesenchyme by which the bone forms initially. In both processes, woven bone is produced first and is soon replaced by stronger lamellar bone. During growth of all bones, areas of woven bones, areas of bone resorptures, and other areas of lamellar bone all exist contiguous to one another. Medical application. Osteogenesis imperfecta or brittle bone disease refers to a group of related congenital disorders in which the osteoblasts produce deficient amounts of type 1 collagen or defective type 1 collagen due to genetic mutations. Such defects lead to a spectrum of disorders, all characterized by significant fragility of bones. The fragility reflects the deficit of normal collagen, which normally reinforces and adds a degree of resiliency to the mineralized bone matrix. Intramembranous ossification. Intramembranous ossification, by which most flat bones begin to form, takes place within condensed sheets or membranes of embryonic mesenchyme tissue. Most bones of the skull and jaws, as well as the scapula and clavicle, are formed embryonically by intramembranous ossification. Within the condensed mesenchyme, bone formation begins in ossification centers, which is in areas in which osteoprogenitor cells arise, proliferate, and forms incomplete layers of osteoblasts around the network of developing capillaries. Osteoid secreted by the osteoblast calcifies as described earlier, forming small irregular spaces of woven bone with osteocytes in lacunae and canaliculi. Continued matrix secretion and calcification enlarges these areas and leads to the fusion of neighboring ossification centers. The anatomical bone forms gradually as woven bone matrix is replaced by compact bone that encloses a region of cancellous bone with marrow and large blood vessels. Mesenchymal regions that do not undergo ossification give rise to endosteum and periosteum of the new bone. In the cranial flat bones, lamellar bone formation predominates over bone desorption at both the internal and external surfaces. Internal and external plates of the compact bone arise, while the central portion or diplo maintains its cancellous nature. The fontanelles or soft spots on the heads of newborn infants are areas of skull in which the membranous tissue is not yet ossified. Endochondral ossification. Endochondral ossification takes place within hyaline cartilage, shaped as a small version or model of the bone to be formed. This type of ossification forms most bones of the bodies and is especially well studied in developing bones, where it consists of the sequence events shown in Figure 8-14. Osteogenesis of long bones and endochondral ossification. First, fetal hyaline cartilage model develops. Second, cartilage calcifies, and periosteal bone collar forms around epiphysis. Third, primary ossification center forms in the diaphysis. Fourth, secondary ossification centers form the epiphysis. Fifth, bone replaces cartilage except the articular cartilage and epiphyseal plates. Sixth is, and last, the epiphyseal plates ossify and forms new epiphyseal lines. In this process, ossification first occurs within the bone collar produced by osteoblasts that differentiate within the perichondrium, transitioning to periosteum, around the cartilage model diaphysis. The collar impedes diffusion of oxygen and nutrients into the underlying cartilage, causing local chondrocytes to swell up or hypertrophy, compress the surrounding matrix, and initiate its calcification by releasing osteocalcin and alkaline phosphatase. In hypertrophic chondrocytes, the hypertrophic chondrocytes eventually die, creating empty spaces within the calcified matrix. One or more blood vessels from the perichondrium, now periosteum, penetrate the bone collar, bringing osteoprogenitor cells to the porous central region. Along the vasculaturely newly formed osteoblasts move into all available spaces and produce woven bones. The remnants of calcified cartilage at this stage are basophilic, and the new bone are more acidophilic. This process in diaphysis forms the primary ossification center, beginning in many embryonic bones as early as the first trimester. Secondary ossification centers appear later at the epiphysis of the cartilage model and develop in a similar manner. During their expansion and remodeling, both the primary and secondary ossification centers produce cavities that are gradually filled with bone marrow and tuberculi of cancellous bone. With the primary and secondary ossification centers, two regions of cartilage remain. Articular cartilage within the joints between long bones, which normally persists through adult life, and the specially organized epiphyseal cartilage, also called epiphyseal plate or growth plate, which connects the epiphysis to the diaphysis and allows longitudinal bone growth. An epiphyseal cartilage is responsible for the growth in length of the bone and disappears upon completion of bone development at adulthood. Elimination of these epiphyseal plates or epiphyseal closure occurs at various times with different bones, and by about age 20 is complete in all bones, making further growth in bone length no longer possible. In forensics or through X-ray examinations of the growing skeleton, it is possible to determine the bone age of a younger person by noting which epiphyses have completed closure. An epiphyseal growth plate shows distinct regions of cellular activity and is often discussed in terms of overlapping by histologically distinct zones, starting with the cartilage farthest from the ossification center in the diaphysis. The zone of reserve or resting cartilage is composed of typical hyaline cartilage. Second, the proliferative zone, the cartilage cells divide repeatedly, enlarge and secrete more type 2 collagen and proteoglycans and become organized into columns parallel to the long axis of the bone. Third, the zone of hypertrophy contains swollen terminal differentiated chondrocytes which compress the matrix into aligned spicules and stiffen it by secretion of type 10 collagen, unique to the hypertrophic chondrocytes in developing or fractured bone. Type 10 collagen limits diffusion in the matrix and with growth factors promotes vascularization from the adjacent primary ossification center. Fourth, in the zone of calcified cartilage, chondrocytes about to undergo apoptosis release matrix vesicle and osteocalcine to begin matrix calcification by the formation of hydroxyapatite crystals. Fifth, in the zone of ossification, bone tissue first appears. Capillaries and osteoprogenitor cells invade the now vacant chondrocytic lacunae, many of which emerge to form the initial marrow cavity. Osteoblasts settle in a layer over spicules of calcified cartilage matrix and secreted osteoid, which becomes woven bone. This woven bone is then remodeled as lamellar bone. In summary, longitudinal growth of bone occurs by cell proliferation in epiphyseal plate cartilage. At the same time, chondrocytes in the diaphysis side of the plate undergo hypertrophy. Their matrix becomes calcified and the cells dies. Osteoblasts lay down a layer of new bone on the calcified cartilage matrix. Because the rates of these opposing events, proliferation and destruction, are approximately equal, the epiphyseal plate does not change thickness, but is instead displaced away from the center of the diaphysis as the length of the bone growth increases. Growth in the circumference of long bones does not involve endochondral ossification but occurs through the activity of osteoblasts developing from osteoprogenitor cells in the periosteum by a process of appositional growth, which begins with formation of the bone collar of the cartilaginous diaphysis. As shown in Figure 8-18, the increasing bone circumference is accompanied by enlargement of central marrow cavity by the activity of osteoclasts in the endosteum. Medical application. Calcium deficiency in children can lead to rickets, a disease in which bone matrix does not calcify normally and the epiphyseal plate can become distorted by normal strains of body weight and muscular activity. Ossification processes are consequently impeded, which causes bones to grow more slowly and often become deformed. The deficiency can be due either to insufficient calcium in diet or a failure to produce the steroid prohormone vitamin D, which is important for the absorption of calcium by cells of the small intestine. In adults, calcium deficiency can give rise to osteomalacia, characterized by deficient calcification of recently formed bones, partially decalcification of already calcified bones. Bone remodeling and repair. Bone growth involves both the continuous resorption of bone tissue formed earlier and the simultaneous laying down of new bone at a rate exceeding that of bone removal. The sum of osteoblast and osteoclast activity in growing bone constitutes osteogenesis, or the process of bone remodeling, which maintains the bone's general shape while increasing its mass. The rate of bone turnover is very active in young children, where it can be 200 times faster than that of the adults. In adults, the skeleton is also renewed continuously in a process of bone remodeling that involves the coordinated localized cellular activities for bone resorption and bone formation. The constant remodeling of bone ensures that despite its hardness, this tissue remains plastic and capable of adapting its internal structure in the face of changing stress. A well-known example of bone plasticity is the ability of the positions of teeth in the jawbone to be modified by the lateral pressure produced by orthodontic appliances. Bone forms on the side where traction is applied and is resorbed on the opposite side where pressure is exerted. In this way, teeth are moved within the jaw while bone is being remodeled. Because it contains osteoprogenitor stem cells in the periosteum, endosteum, and bone marrow is very vascularized. Bone normally has excellent capacity for repair. Bone repair after fracture or other damage uses cell signaling molecules and processes already active in bone remodeling. Surgically created gaps in bone can be filled with new bone, especially when periosteum is left in place. The major phases that occur typically during bone fracture repair include initial formation of fibrocartilage and its replacement with temporary callus of woven bone. Okay, figure 8-19 main features of bone repair. First, a fracture of hematoma forms. Second, a fibrocartilaginous or soft callus forms. Third, a hard bony callus form. And the fourth, bone is remodeled. Okay, medical application. Bone fractures are repaired by a development process involving fibrocartilage formation and osteogenic activity of the bone cells. Bone fracture disrupts blood vessel, causing bone cells near the break to die. The damaged blood vessel produces localized hemorrhage or hematoma. Clotted blood is removed along the tissue debris by macrophages and matrix of damage. Cell-free bone is resorbed by osteoclasts. The periosteum and endosteum at the fracture site respond with intense proliferation and produce a soft callus of fibrocartilage-like tissues that surrounds the fracture and covers extremities of the fractured bone. Fibrocartilaginous callus is gradually replaced in a process that resembles a combination of endochondral and intramembranous ossification. This process produces a hard callus of woven bone around the fracture ends of bone. Stresses imposed on the bone during repair and during the patient's gradual return to activity serve to remodel the bone callus. The immature woven bone of the callus is gradually absorbed and replaced by lamellar bone, remodeling and restoring the original bone structure. Metabolic role of bone. Calcium ions are required for the activity of many enzymes and many proteins mediating cell adhesion, cytoskeletal movement, exocytosis, membrane permeability, and other cellular functions. The skeleton serves as the calcium reservoir containing 99% of body's total calcium and hydroxyapatite crystals. The concentration of calcium in the blood, which is 9 to 10 milligrams per deciliter, and tissues is generally quite stable because of a continuous interchange between blood calcium and bone calcium. The principal mechanism for raising blood calcium level is the mobilization of ions from hydroxyapatite to interstitial fluid, primarily in cancellous bone. Calcium mobilization is regulated mainly by paracrine interactions among bone cells, many of which are not well understood. But two polypeptide hormones also target bone cells to influence calcium homeostasis. Parathyroid hormone or PTH from the parathyroid gland raises low blood calcium levels by stimulating osteoclasts and osteocytes to reabsorb bone matrix and release calcium. The PTH effect on osteoclast is indirect. PTH receptors occur on osteoblasts, which responds by secreting RNKL, RENKL, and other paracrine factors that stimulate osteoclast formation and activity. Calcitonin, produced by the thyroid gland, can reduce the elevated calcium levels by opposing the effects of PTH in bone. This hormone targets the osteoclast to slow matrix resorption and bone turnover. Medical application. In addition to PTH and calcitonin, other hormones act on bone and anti-bone. The anterior lobe of the pituitary growth hormone or somatotropin, which stimulates the liver to produce insulin growth-like factor 1 or IGF-1 or somatomedin. IGF has overall growth promoting effect, especially on epiphyseal cartilage. Consequently, lack of growth hormone during growing years causes pituitary dwarfism, and excess bone growth hormone causes excessive growth of the long bones, resulting in gigantism. Adults' bones cannot increase in length even with excess IGF because they lack epiphyseal cartilages, but they do increase in width by periosteal growth. In adults, an increased growth hormone causes acromegaly, a disease in which bones, mainly the long bones, become very thick. In rheumatoid arthritis, a chronic inflammation of the synovial membranes causes thickening of this connective tissue and stimulates the macrophages to release collagenases and other hydrolytic enzymes. Such enzymes eventually cause destruction of the articular cartilage, allowing direct contact of bones projecting into the joint. Joints. Joints are regions where adjacent bones are capped and held together firmly by other connective tissues. The type of joint determines the degree of movement between the joints, between the bones. Joints classified as synarthrosis allow very limited or no movement and are subdivided into fibrous and cartilaginous joint, depending on the type of tissue growing on the bones. Major types of synarthrosis includes the following. Synostosis involve long bones linked to other bones and allow essentially no movement. In older adult, synostosis unite the skull bones which in children and young adults are held together by sutures or thin layers of dense connective tissue with osteogenic cells. Next is syndesmosis. Joint bones by dense connective tissue only. Example includes the interosseous ligament of the inferior tibiofibular joint and the posterior region of the sacroiliac joints. Last, the symphysis have a thick pad of fibrocartilage between the thin articular cartilage covering the ends of the bones. All symphysis, such as the intervertebral disc and pubic symphysis, occur in the midline of the body. Next is the intervertebral disc, a large symphysis between the articular surfaces of successive bony vertebral bodies. It is held in place by ligaments. These discoid components of the vertebral joints cushion the bones and facilitate limited movements of the vertebral column. Each disc has an outer portion, the annulus fibrosus, consisting of concentric fibrocartilage laminae in which collagen bundles are arranged orthogonally in adjacent layers. The multiple lamellae of fibrocartilage produce a disc with unusual toughness, able to withstand pressures and torsion generated within the vertebral column. Situated in the center of the annulus fibrosus, a gel-like body called nucleus pulposus allow each disc to function as a shock absorber. The nucleus pulposus consists of various fluid matrix rich in hyaluronan and type 2 collagen fibers, but also contain scattered vacuolated cells derived from the embryonic notochord, the only cells of that structure to persist postnatally. The nucleus pulposus is large in children, but these structures gradually become smaller with age and are partially replaced by fibrocartilage. Medical application. Within the intervertebral disc, collagen loss or other degenerative changes in the annulus fibrosus are often accompanied by displacement of the nucleus pulposus, a condition variously called slipped or herniated disc. This occurs most frequently on the posterior region of the intervertebral disc, where there are fewer collagen bundles. The affected disc frequently dislocates or shifts slightly from its normal position. If it moves towards nerve plexuses, it can compress the nerves and result in severe pain and other neurologic disturbances. The pain accompanying a slipped disc may be perceived in areas innervated by compressed nerve fibers, usually the lower lumbar region. Joints classified as diarthrosis permit free movement of bone movement. Diarthrosis, such as in the elbow and knee, generally unite long bones and allow great mobility. In diarthrosis, ligaments and a capsule of dense connective tissue maintain proper ligament of the bones. The capsule encloses sealed joint cavity containing a clear viscous liquid called synovial fluid. The joint cavity is lined not by epithelium but a specialized connective tissue called synovial membrane that extends, folds, and villi into the joint cavity and produces the lubricant synovial fluid. In the indifferent diathrotic joints, the synovial membrane may have prominent regions with dense connective tissue or fat. The superficial regions of these tissue, however, are usually well vascularized with many porous or fenestrated capillaries. Besides having cells typically of connective tissue proper and a changing population of leukocyte, this area of synovial membrane is characterized by two specialized cells with distinctly different functions in the region. The first, the macrophage-like synovial fluids, also called as type A cells, are derived from blood monocytes and remove water and wear and tear debris from the synovial fluid. These modified macrophages, which represents approximately 25% of cells lining the synovium, are important in regulating inflammatory events within diarthrotic joints. Fibroblasts, synovial cells, or type B cells produce abundant hyaluronan and smaller amounts of proteoglycans. Much of this material is transported by water from the capillaries into the joint cavity to form the synovial fluid, which lubricates the joint, reducing friction on all internal surfaces and supplies nutrients and oxygen to the articular cartilage. The collagen fibers of the hyaline articular cartilage are disposed as arches with their tops near the exposed surface, which, unlike most hyaline cartilage, is not covered by perichondrium. This arrangement of collagen helps distribute more evenly the forces generated by pressure on joints. The resilient articular cartilage efficiently absorbs the intermittent mechanical pressures to which many joints are subjected.